Welcome, conversing listeners. What is the credibility of the faith in a time like this? The Rethinking Church Initiative is launching a new podcast called Credible Witness.
I'm Nikki Toyamasito, and this is Credible Witness, a collection of stories and wisdom from faithful people wrestling with and bearing witness to the credibility of Christian life today. Each episode is an invitation to listen generously and courageously to one person, navigating social tension and moral complexity, negotiating doubts, struggles, and fears, overcoming obstacles and pursuing justice, and living out the convictions of their faith. And every voice reminds us that the church is called to be a credible witness to Christ, a living reality of hope, justice, truth, and love.
It's a beautifully rendered collection of stories that reward a courageous and generous listening. So please check out our show notes for links to the Credible Witness podcast feed, as well as crediblewitness.us. I'm hoping that you'll subscribe today, and I believe you'll be deeply encouraged by the series of episodes to come. Thank you for listening courageously with me, and may God bless this new effort.
Conversing is produced and distributed in partnership with Comment Magazine and Fuller Seminary. I'm Mark Labberton. Welcome to Conversing. It's such an honor to me today to be able to welcome Eric Ha as our guest on Conversing. Eric is currently the president and CEO of Medical Teams International, an organization that provides primary medical care in places of critical need in some of the most devastated parts of the world. Frankly, the work that they're doing is staggering in its challenges and in its importance. He comes to this role with a great background, having worked with International Justice Mission, in part as its COO for many years, and as an attorney whose education has helped him prepare with particular expertise in these kinds of roles. It is a great personal joy and honor to me to welcome him today. Eric Ha, welcome to Conversing. I'm so glad that you're here today.
Thanks, Mark.
You know, I've been an admirer of yours when I first met you when you were in a critical role in International Justice Mission. And now that you've taken on the role of being CEO of Medical Teams International, it feels like such a great fit from the outside, and it feels like a great use of your gifts. And so I'm just eager for people to know you and to know more about what you're up to, especially because, as you know better than I do, but all of us know, that we're in a period where so much has changed about American foreign aid and the way that it intersects with global needs of various kinds, not least medical ones, in the case of concerns that your mission is really addressing. So I'm anxious for you to give us that picture. So why don't you first just give us a little bit of your background, and then I'd like you to sketch the picture of Medical Teams International.
Great. Well, thank you, Mark. It's a real privilege to get to be here with you. My journey and really ending up at Medical Teams was not something that was mapped out and choreographed in any way. In many respects, it has felt like very much a full circle bringing together of a number of different threads that the Lord has sort of woven together, ranging from my childhood and family of origin through my professional experiences, both as a lawyer in private practice and then certainly the 11 just remarkable years that I got to spend at IJM. And so I'm really grateful to be part of a mission that actually is very close to my own family history and the ways in which my family has been deeply impacted by the work of the church over the years, but then also drawing upon my professional experiences to get to be put, in this very, what feels like to me a very sacred position of inheriting and stewarding an organization that has been doing really remarkable work for almost 50 years now. So Medical Teams International began in response to our founder, Ron Post, just feeling the conviction of God in response to the suffering of the people of Cambodia during the killing fields and wanting to do something. And so within weeks of seeing a news story on TV, had assembled a group of doctors and nurses and other health professionals to go to Thailand to care for Cambodian refugees. And so that was the very start of Medical Teams. And there is a real through line to the work that we now do almost 50 years later. To paint it very broadly, what Medical Teams does is provide and create access to primary health care for crisis-affected people. And right now, and over the decades, that's what we've done, and it's taken different shapes and forms.
Sure.
Today, the bulk of that work is in East Africa, where there's just a persistent and really complex crisis of forced displacement and refugees. And so we are really the primary healthcare partner for the UN Refugee Agency in most of the countries where we operate. We have programs in Uganda, Ethiopia, Tanzania, and Sudan. And there just continue to be these crises that then create and result in the crisis of forced displacement.
Right.
And so that's primarily what we do. We also have a program in Ukraine, responding to the conflict and war there, in Colombia, working with Venezuelan migrants, and then also in the United States, we have programs as well.
So in East Africa, how many displaced people are in the catchment areas, the nations that you named?
I believe about 7 million.
Right.
In total, our catchment areas across all our programs are over 9 million.
9 million.
And so it's quite significant. And that catchment area certainly includes the refugee populations in the camps that we work in. We also do quite a significant amount of care for the surrounding host communities. And depending on the country and the camp, that could be 20 to 30% of our catchment area. In Sudan, even though we're stationed in refugee camps, the majority of our care is actually to Sudanese who live around the camps. So it's not constrained by the refugee population,
right,
and expands out from there.
And by primary care, you mean all ages, all circumstances, whatever the presenting health crisis may be.
Yeah, and primary healthcare is relatively well defined at this point because they are the basic human necessities that actually have the most significant impacts on, there's this term preventable death and suffering. And so it includes things like maternal care, vaccinations, mosquito nets, anti-malarials, anti-diarrheals. Mental health is a surging need that falls under primary health care. So they're quite well-established interventions that have really dramatic health outcomes for the populations in need.
Right, right. So take us to one of the places to give us a window into what you're describing in Africa. And then I know you fairly recently returned from a trip to Colombia. So give us windows into both of those two areas.
Sure. Probably about 6 or 7 months ago, I traveled to our programs in Ethiopia and Uganda. And Mark, I'll tell you, over the years with IJM and even before, I traveled to some very dark places. But in all that time, I'd never actually gone into a refugee camp.
Mm-hmm.
And it was an extraordinarily powerful experience to do that. The standard of living in a refugee camp it's almost like going back in time, a century or more.
Mm.
One of the great challenges in this space is 30 or 40 years ago, I think the crisis of displacement and migration of people was very different.
Right.
Today, the average length of time that a refugee spends displaced is approaching 20 years.
Mm.
That's nearly a generation. That's a full development cycle for a human. But the response mechanisms are still treated as these short-term emergencies. And so, for example, a house or shelter in a refugee camp is still plastic tarps and wood and thatched roofs. There is often no electricity, very limited access to running water, let alone clean water. And that is the environment in which people live for sometimes 10, 15, 20 plus years. Now, if that's for 6 months, you can maybe, grit it out and endure it.
Right.
But entire communities live in those conditions today. And it's in those settings where medical teams is very often the sole provider of even this base level of healthcare. And so one of the things that I learned and got to see is the amount of need for even basic things like maternal support pre, during, and post-delivery. Maternal mortality is, you can just imagine, it's just a tragedy. But what we found is even the most basic level of care and the equipping of community support around pregnant mothers has a huge impact,
I bet,
on being able to safely deliver children. Last year, medical teams staff helped deliver 50,000 babies.
Oh my God.
That's a delivery every 10 minutes somewhere around the world in these extraordinarily harsh settings. But our maternal mortality rates were orders of magnitude better than the national averages where we work. So there's this huge significance to the impact of the care that we're providing. But the other thing that I got to see was sometimes it's so easy to get lost in the statistics of the last UN estimate, or there's 123 million forcibly displaced people in the world today. That's kind of a paralyzing number where you can just get lost in the number. But what I got to see in these camps is these numbers are these humans that bear the image of the divine and the eternal and the holy and the sacred. And you get to see these glimpses of the laughter and the joy and the human experience that still exists in these places. And so the enormous joy of the birth of a safely delivered child,
right,
is as real as the tragic loss of a life and the suffering that exists in those places. And so the ability to be present in those places with our just extraordinary staff,
right,
who literally live in those places for weeks at a time to provide that care that acknowledges the dignity of each human was just extraordinarily powerful.
Right. And what you're describing, I think, was mostly in East Africa. But what about the circumstances in Colombia? Are they the same, different? Tell us about that.
In some ways, very similar. And so the target population that we work with in Colombia are largely Venezuelan migrants coming into the country. But again, that's not like a defined area or population. And so it certainly encompasses some of the local communities in more remote and rural areas in the country. I got to visit a village community of Venezuelan migrants that we had worked with for quite some time. And our model is a little bit different because it's not in a refugee camp that's administered by the UNHCR in Colombia. It is much more around coming alongside a community, mobile units that come in to service a community, or more in partnership with government health facilities and really equipping the community to access and utilize them. But the needs are very similar, and the conditions are actually quite similar. The really heartbreaking thing in Colombia when I visited is Colombia has been very, very significantly impacted by the pullback in foreign aid. And really all of Latin America has. And I was provided with some statistics about how the level of aid between 2024 from the United States as compared to 2025 is something well below 10% of the level of aid.
Only 10% this year of what had been given even last year.
Yeah. And 2026 is likely going to reduce even further. And so that pullback in aid has had a very visible impact on the support that these communities are getting. And even medical teams has had to dramatically scale back our work in Colombia. And the number of organizations that have had to pull out is very, very significant. And so to be there in a community that has been so positively impacted by our work, and to know that that's scaling back even further is really heart-wrenching.
Really heart-wrenching. So let's just pause for a minute. I want to hear a little bit more about the transition as you've taken on this responsibility. For years, you worked in a very exceptionally important role with International Justice Mission, and whose work principally has to do with bringing about securing justice and rescue, but also accountability for perpetrators in human trafficking and various other kinds of human slavery, and then to also change public justice systems to become functioning, sustainable public justice systems that are defending and protecting women and children especially. Now you switch from that mission field, which heavens knows continues on and is every bit as great as it has been. And now you're focusing really not on the social reality so much as the medical reality in light of the social reality that's surrounding it. So what has that meant in terms of your own heart and mind, moving from one kind of extremely important work to another kind of but different, extremely important work?
Wow, that's a great question, Mark. It has definitely been a transition, and it is different. IJM interestingly kind of straddles both of these spaces in a way that I've come to appreciate even more, having come into a different space.
I can imagine.
But certainly IJM's origins were very much rooted in the one child suffering. And I remember Gary talking about in the early years, the rescue of one child would have been enough. And it absolutely would have been. And over time, it's grown and expanded into this more system reform, protection of vulnerable populations, which is amazing. In the more humanitarian space, where and the primary healthcare space, where it really is a person who is presently suffering, who is presently in a state where they could die.
Right.
There's certainly the immediacy of need and impact that is extraordinarily powerful and compelling. The challenge is the growing scale and size of need and this feeling of insufficiency and inadequacy to meet it means that preventable death and suffering is not actually being prevented.
Right.
And I think what the bigger systemic, even theory of change allows you to do is have hope.
Yes.
That over time, if we just pound away at this model and theory of change long enough, the root cause will be addressed and slavery will be no more. Violence will be no more. It's very hard to map that out in a situation like East Africa, where for decades, these complex cycles of internal conflict, of war, of famine, are contributing to this condition of displacement.
Right.
That only seems to be getting bigger.
Right.
And so finding the thread and kernel of hope
Yes.
is actually a lot more challenging.
Right. Right.
And so for me, the drawing near to the actual front line of our work to engage with the actual faces and humans that are receiving the care, and to see the actual humanity that is being dignified and preserved,
yes,
is super important. But it is both common and I think quite understandable why in the humanitarian space there is a lot of burnout. There can be a lot of cynicism.
Absolutely.
But finding the hope is actually even harder, I'm finding, than in some other spaces I've been involved in.
I think it's so important to dwell on this for just a bit more, because one of the things that happened when USAID was ended and PEPFAR, the program specifically related to HIV/AIDS, was brought to a close, is from a distance just a dollars and cents decision. But it's nothing but a humanitarian crisis on the ground. And and the depth of that kind of pulling away of American presence, which for all of its varying dimensions, did secure for a lot of people at least a greater sense of a residue of hope that came from a relatively stable presence of American dollars and personnel. And for that to come so abruptly to an end in a way that was so chaotic and, in my view, really badly handled, it feels as though it just lets the devastation that was there just immediately take over the whole circumstance. And at least that's how it appears. Is that a fair description of what you feel like you've been observing?
Yeah, I think it's a very fair description, especially on my recent trip to Colombia. The general feeling of despair and hopelessness was palpable. I do think that is part of the opportunity in front of us. Is there is a reality and a validity to that, but especially as Christians, I don't think that is what Jesus would have us see in this.
Right.
Obviously, it's very different for the person living in a community who all of a sudden loses access to the things that were sustaining life in those areas. But I do think there is opportunity for us to acknowledge what might have been an over dependence or even a mental over reliance on established institutions and patterns of funding. But even the abrupt withdrawal of the last 9 months is not the end. It is a season of a much longer narrative.
Right.
And so it's very hard when you are in the community that has been really devastated by it. But zooming up a bit in terms of my place, medical team's place, other organizations' places, the church's place in all of it, I don't think we can just end with despair.
Right.
As real as that feeling actually is.
Of course, even compelling. I wonder, Eric, when you think about what work you're doing, and you do think about churches, local churches, you think about churches in the United States, you think about partnering international organizations, give us a picture of how you're understanding that. I want to underscore for the listeners that you've only been at this job for a very short period of time, and you came about right in the middle of one of the greatest crises in foreign aid that has ever occurred. And now suddenly you're in charge of an organization that's trying to do already impossible things made even more impossible. So,
well, it's even better than that, Mark. I joined right before the upheaval of the system of foreign aid. So the timing was really couldn't have timed it better.
Yes.
It's interesting. I obviously did join a new organization in a new role at a really precipitous time. But in some ways, the way that I'm approaching it is part of a meta journey about understanding my place, the church's place, parachurch ministry's place in the longer arc of God's kingdom.
Right.
And what I've observed over the last 9 months is very much in line with things that I had been kind of chewing on for several years, especially as it relates to public funding of actually kingdom building work. And in many ways, it's quite remarkable and I think quite a legacy of the church over centuries to have created a world in which governments and public institutions actually believe that care for the poor and the vulnerable is something that public institutions should care about and actually fund.
Right.
And as big as the dollars can seem, U.S. foreign aid is a fraction of a percent of the U.S. GDP. And that's actually even higher than most other countries' contributions.
Right.
And so, yes, we're talking about tens of billions of dollars in the aggregate, but compared to global wealth and global GDPs, it is a fraction of a percent. But even that is a significant thing when you compare our culture and our society and our governments to ancient Rome or ancient Greece, that cultures that were entirely rooted in exploitation of the poor and the vulnerable.
Right.
So that's a really significant thing. But in some ways, the success of having advocated and mobilized, just take the U.S. government, for example, to create a program like PEPFAR,
yes,
which was very much the result of the church advocating.
Right.
In some ways, it kind of went too far in the sense that the world and parachurch ministries and the church even in some ways began to associate that with a responsibility then that sat with the government or with these public institutions, when fundamentally it has always been the calling and purview of the church to be in those places. And it's not a either or, it's all the church's responsibility or all the government's. There is a sweet spot where we have mobilized and advocated for a government to actually govern consistent with the morality and ethic of Jesus's teachings, but then to partner with that and come alongside it. And what the withdrawal of foreign aid, the abrupt withdrawal revealed to me, especially in the refugee care for global refugee spaces, that work had largely been outsourced to the UN and the UN Refugee Agency.
Yeah. Mm-hmm.
And when the funding for that ecosystem was pulled, it kind of came crumbling down. And what it revealed to me was the absence of an actual structural presence of the church that wasn't likewise tied to public funding.
Right.
And UNHCR is barely 75 years old. It's a incredibly recent phenomenon and development. And for thousands of years prior to that, the infrastructure and ecosystem for the care of refugees was the church. It was God's people.
Right.
So that's I think a really
very
troubling
right.
observation.
Yes.
But also then the opportunity to reimagine in this world that we live in now, what should that partnership look like? What could it look like?
Right. Right.
How do we build a structural presence of the church that comes alongside UNHCR, other public multilateral structures, to ensure that the care for the least of these is not actually subject to the political movement and whims of the world around us, but there is a more constant presence that is rooted in the building of God's kingdom.
And based on where you are right now in your new leadership, what insights do you think you're gleaning about what that new kind of infrastructure or relationship might be? I know it's early, but just what are you noticing?
Well, I think it has forced a conversation and real need to explore what collaboration could look like, to reimagine what collaboration looks like within the church and then outside with secular and other institutions as well. And I don't think there is an easy or quick answer to that.
Right.
But again, if we want to look for silver linings, it was the suddenness and the jolt to a system that had been around for decades that I think has created some urgency to actually confront this question of, if that is not around anymore, or if that is fundamentally changing,
yes,
how do we respond, and what is the new thing that can be developed based on decades of having actually learned some things, and what is the new way of operating together. And I will say, especially on the ground locally, there have been some, I think, really good conversations and movement about how to partner with the local church, to partner amongst different ministries and NGOs. Medical Teams has been putting together a coalition of 7 faith-based NGOs and several other secular NGOs to create a much more coordinated, multi-sectoral approach to providing care in Sudan. And that's really exciting.
Right.
But desperation in some way, scarcity, forces some of those conversations to happen with an urgency that doesn't necessarily exist when there's more established and regular funding coming in.
Right, right. One of the troubling things that has been part of the national conversation in the U.S. has been supposedly this loss and even deprecation against empathy. And people are talking about it as a sign of a person's weakness if they are empathetic and so forth. That is different than coalition building. That has to do with people formation. That has to do with an instinct about what it means to be human and how to see our neighbors in human ways, even when our neighbors may be geographically distant and are culturally different. And I guess I'm just curious, have you run into that conversation in this collaboration you're describing? I'm assuming it's mostly with people who are, as it were, the empathetically converted, or they wouldn't be involved in international relief and development work. But just talk to us about that.
Well, I think what you're describing is such a critical orientation for us as individuals, for us as a society, to actually create sustainable flourishing, is an orientation towards empathy. And even within the industry of international aid or development, humanitarian work, over time, I think there is, without intentionality, there is very easily a way to actually move away from empathy. And so just because you're in the industry doesn't mean you actually have an empathetic orientation. And again, especially in moments of crisis, I think what often comes to the surface is out of our orientation. And so, to be perfectly honest, there are absolutely organizations and individuals from a survivalist scarcity mindset are not first and foremost looking at the plight of those that we're trying to serve, but like, as an organization, how do we survive?
Right.
And I think part of the gift that we have of being rooted in our faith in terms of defining our orientation to the work is to know that we're all just invited into a bigger work that God is doing, that we've been promised for. Like, we know what the end destination is, and the victory's been secured. And in all these ways, we are invited into a different orientation.
Right.
And that empathy piece, I think, is so critical, because it is the thing that allows us to to actually engage in productive conversations about how to collaborate, about how to actually serve and deliver what's needed for those in need the best. And that's not just about refugee camps in Sudan. I think even locally, a posture of empathy helps us actually navigate the complexity of, well, why are we spending money halfway around the world anyway? We have needs here. And that's absolutely true. Absolutely true. But it's a very different posture to look at that through a lens of empathy versus one of that scarcity, self-interested mindset. It's a totally different conversation.
And the competitiveness that can sometimes exist between international organizations and the fight for institutional survival, for scalability, for effective, quote, systems, all those things have their own legitimate place as part of the furniture of the enterprise. But I don't really understand I do understand why I think empathy could be lost, but I don't understand how a person could remain in it for the long haul without that. And yet empathy always costs. It may be the highest cost because it means you're willing to walk into places of exceptional pain and need vulnerably rather than impermeably. And I think especially this is where the work of doing medicine, which is absolutely, obviously, a hands-on, body-to-body, breath-to-breath kind of connectedness, the actual delivery of goods and services on the ground is both highly vulnerable and empathetically determinative, it seems to me. I went just yesterday to see a doctor about a small matter. I got a time with the doctor. I waited months for this, and the appointment lasted less than 5 minutes. And it was stunning to me. And it wasn't because I needed 10. I didn't even need 7. I could have done with a full 5, however. That would have felt like, okay, there was in that 5 minutes a beat or two where actually we were doing more than just the fastest possible mechanics around the thing that I had gone in to see the doctor about. And it was really breathtaking to me. Obviously, there's plenty of people in the world that would long for less than 5 minutes with a doctor. So I'm not trying to make me a victim in the least. I'm just saying that was just an interesting window into the ongoing development of machine-like medicine. And even that would be better than what many, many, many people in the world have.
Yeah.
But it's the empathy piece that feels like it's puts us on the journey to healing in a way that's quite different than simply the mechanics. Let's talk a little bit about the mental health piece. You mentioned that as a growing part of the work of medical teams. So what can be done about mental health in a context like the ones you've been describing? It already feels like it's an ocean of just raw biological need. And then you have the psychological needs as well.
It is, because so many of those populations that we work with, by definition, have experienced trauma.
Right.
So, of course, there are going to be mental health implications to that. And I think it is one of the benefits of the increase in dialogue around mental health globally has made it, I think, easier to talk about the importance and need for mental health in places and with people who have very directly lived through trauma.
Right.
Like extreme trauma.
Yes, yes.
And it goes a little bit to that idea of hope and what is the long-term impact of the immediate care that's being provided. So in a place like Sudan, for example, there are the average age in sub-Saharan Africa is extremely young. I don't remember the precise number, but I think it's around 18 or 19 years old.
Yes, very, very young.
And that is the future of sub-Saharan Africa. And if those children are experiencing trauma and all of the effects on their mental health now, like what kind of future is that setting up for the country? And so even just the recognition and elevation of mental health as a primary healthcare need for those populations, imminently and acutely now, but then also for the trajectory that puts them on for the future, is really, really significant. How you do that, much like a lot of the primary healthcare interventions that we do, like there's a spectrum of mental health support services interventions that are available. And in these settings where there's such a scarcity of services and support, even a little bit goes a long way in terms of impact. And so training our health workers, training especially the community and community health workers and community volunteers to create safe spaces for children, to recognize signs of mental distress, and to have even a basic level of programming to help kids process their trauma. It is actually extraordinarily impactful. And so I actually just returned from New York last night because the Clinton Global Initiative was highlighting our work on mental health with children in Sudan.
I see.
And sort of profiling our commitment to expand that programming in the future. So when you stop and think about it for even a second, it is a plainly obvious need.
Absolutely.
And we're working to continue incorporating that into this space of just basic primary care, especially in these distressed places that we work in.
Right. I don't know that we've talked about this before, Eric, but I believe you may have come in contact with a man named Tim Friesen, who,
of course,
is a therapist and has done extraordinary work with children. And his project, called the Jacaranda Project, is one that I've had very close association with. And what they're doing on the ground in places of violence and war is really, really transformative in the way that you're describing. And I just want to underscore for listeners and for people who are trying to understand and calibrate, how do you respond? What are the kinds and levels of needs that helping the very young child be able to somehow find some strength and capacity building for being able to simply endure the trauma that is their life and would seem to be, at least at the moment, largely their future. And the kind of work that Tim and others are doing in this arena feels so significant. And I'm eager on another occasion to learn more about what Medical Teams is doing. But I'm delighted that you got featured in that way. If you were to speak to three audiences, I'd like to close our interview with you offering some words of reflection in three different directions. So let's start with, if you were speaking to the listeners directly, and you were to say, in light of what you're seeing and doing, and the kinds of needs that you're exposed to, certainly financial support is needed, but what would you want people who are hearing this interview to most do as a consequence of what's been highlighted?
What a great question. I think what I would want listeners to take away from this is, I think in our society, in our culture, there are these super currents that are pushing us inward, that are pushing us against an expansive view and holding of things into smallness in some ways. And so we were talking earlier about, even statistics sometimes, like 123 million forcibly displaced people, can feed into that current and say, well, that's like too big of a problem. Like I can't even engage in that. I'm going to let the current turn me inward.
Right.
And I I just don't think that's ever been the invitation of the gospel, to turn exclusively inward. I think if anything, the gospel is an outward pushing invitation. And in my experience, it is the pushing outward that has expanded my own experience and understanding of the vastness of God, which then turns back inward into like a strengthening and deepening of my own faith.
Yes.
But it is the pushing out actually into the far and remote places of suffering and need.
Yes.
And to see the presence of God.
Yes.
And the image of God in those people.
Right.
To get an understanding of the vastness of God's love for all of his creation, for the vastness of God over all of these things that may seem insurmountable to us in the moment, but actually are not at all hurdles to the trajectory towards the coming kingdom. And so the invitation, I think, would be to not feel overwhelmed and to not allow these cultural currents to push us inward and to have this like very small experience and perception of who God is, what God cares about, and what God's doing, but to stretch the proverbial rubber band further and further, because God actually fills all of that space and beyond.
Amen.
And that's not to in any way say it's just like geographic in scope, but it's even the depth of exploration.
Yes.
In our own backyards.
Yes. Yes.
That I think stretches us and gives us a bigger experience and perception of just how vast the love of God is.
Right. Amen.
That would be the invitation, I think, I'd want to share.
That's a really great word. What about to churches? If you had a cavalcade of church leaders before you and you were going to say to them, what are the consequences of this that you would want them to consider, to act on, to actually perform, to do something about?
Oh, another great question. And what I'll confess I've been thinking about a lot and don't actually have an answer to, and have
Fair enough.
Actually been seeking and pursuing conversations to understand better. I have a profound appreciation for the difficulty that comes with being a pastor or a church leader today. The spectrum of things that are bombarding our minds and our news feeds, the polarization of our society.
Yes.
Trying to steward and shepherd a congregation,
right,
or the body of Christ through that's really hard to do. In some ways, I have had the benefit for many, many years now of almost being like a single issue Christian. These are the things that I care deeply about, and therefore I think you should care about those things too.
Yes.
That may be true, but in terms of what I would want like churches and church leaders to hear and know is, certainly for me, is my own recognition of how unhelpful it is for me to simply pound a drum that says, here's what I'm deeply passionate about, convicted about, like you should be too, and in your congregations, the body of Christ should be too.
Yes, yes.
What I'm trying to figure out, and would love to continue exploring with you, Mark, and others, is what is the right place for example, what we just talked about in terms of this seeking out and broadly and deeply of the vastness of God as it relates to human suffering. What is actually the right positioning and place for that within a broader thing that the church is trying to do and trying to respond to, which is like it's placed in these super currents of our culture.
Right.
How does it actually fit in?
Yes.
So in some ways, what I would want to say to the church and to churches is to say, to help me and to help other parachurch ministries understand how we can fit into and help a much bigger thing that the church, I think, is having to confront within our society, within our culture.
Right.
Because what I desperately don't want to do is just be a distraction.
Right.
Or some single issue thing that only muddies the water even more.
Right. I think that's a beautiful picture. So then in closing, tell us how we could pray for you and for medical teams.
I think the ability to see and to hold on to hope, and in particular for our frontline teams who, again, are working and oftentimes living in definitionally traumatic environments.
Mm-hmm.
And within that environment to then add on this uncertainty and withdrawal of resources and funding, and having to make decisions to close health facilities or to pull back on care when they are literally seeing in front of their eyes
Right.
the need.
Right.
The ability to see and to hold on to hope, I think, would be a miraculous provision that I would love for you and others to be asking for on their behalf, on our behalf.
Yes.
In the same way, I think, this may sound odd, but the patience to wait upon the Lord,
Mm-hmm.
I felt in my own heart at times this feeling of we just need to go out and get and find ways to replace or to supplement.
Right.
And there's always work to do, but I think praying for the provision of this miraculous provision of patience to wait upon the Lord, and for the Lord's provision. At my board meeting a few weeks ago, we were reflecting on the image of a rowboat versus a sailboat.
Uh-huh.
And the source of power is different between the two.
Yes. Yes.
And the continued grounding in how you operate a sailboat.
Yes.
And sometimes the different nature of the work to be positioned to catch the wind, and oftentimes the patience to wait upon the wind, is just a completely different orientation than rowing harder.
Right. Right.
And so I think for all of us, maybe for me in particular, this patience to wait upon the Lord. And then in all of that is just great wisdom to make really hard decisions in the midst of that patient waiting, in the midst of that holding on to hope. There actually are very difficult decisions that are in front of us. And we just want to do those as wisely as we can.
Eric, you've given us a profound and moving insight into the reality on the ground and in responsive organizations, not least Medical Teams International, in trying to live into and through this moment of global reset that is unfolding before our eyes. And I'm just, again, extremely grateful for you, extremely grateful for the leadership role that you're now exercising at Medical Teams, and moved by the courage and the faithfulness and the resilience that you are exhibiting even in the face of such staggering challenges. I just thank you for what you and Medical Teams are doing, as you and I have both celebrated what the work of IJM is doing and other organizations in their own respective ways, and local churches are doing. It is just such a headwinds season, and more, it seems, each day. So thank you for giving us these gifts and for our friendship and for the gift of being partners going into this uncertain future.
Thank you so much, Mark. It's been a real pleasure, as always, to get to chat with you. Thanks so much.
Conversing is produced and distributed in partnership with Comment Magazine and Fuller Seminary. Peter Labberton is our engineer and editor. Evan Rosa is our producer. For more information about Comment Magazine, visit comment.org, where you can subscribe, read the current magazine issue, and browse their archive. Fuller Seminary is an evangelical, multi-denominational graduate institution committed to providing indispensable formational education for for diverse Christian leaders everywhere. For information, visit fuller.edu. I'm your host, Mark Labberton. Thanks for listening with me.